Okay, for this lecture, we'll begin discussing heart failure. So I want us just to remember, like, heart failure is not a disease by itself. It's more of a classification system that we use to talk about these cardiomyopathies and the ejection fraction. So clients with heart failure can actually have issues, either systolic blood pressures or their diastolic pressures. A lot of the times it will just be annotated as S or D, so S heart failure, SHF, or DHF. We're using that information to basically look at how well that client is able to maintain cardiac output and how well they're able to perfuse. There's a couple types that they talk about, and you may see these in your notes or their histories. So if you see HF and then it has a small r, it's talking about a reduced ejection fraction, so that's the more severe, so that EF is typically less than 40. You have significant impaired contractility with a preserved ejection fraction, so that EF will typically be somewhere around 50 and above. What you have now is an impaired relaxation. And that's really all you need to understand about systolic or diastolic heart failure until you get into some NP classes or your critical care classes. Heart failure can have an abrupt onset. So if we talk about acute decompensated heart failure, you're probably going to end up with some sort of flash pulmonary edema. But heart failure in and of itself can just be an insidious process where our body has compensated for so long that we don't even realize that we have a cardiovascular issue. So in the notes, you will see acute on chronic, acute heart failure. You will see acute decompensated heart failure. It's just to let you know that, hey, we had a history of heart failure and now their signs and symptoms are no longer manageable at this time. Once we do our interventions, we'll hope to fix those. And what we don't want to see is that we are getting all the way through our treatments and we notice that we have not been taking care of the underlying problem. Because usually when you go into an acute on chronic issue with heart failure, there is an underlying comorbidity. So maybe it's an infection, maybe it's dehydration, maybe it's myocardial ischemia. We've got to figure out what the underlying cause is and treat those causes. Because once we get here, it's acute decompensated. It's harder for us to control those compensatory mechanisms, and they're going to end up with a flash pulmonary edema, which if you do not recognize right away is going to be a life-threatening situation. And I've had this, and the client went from satting 98 to 68 in the matter of seconds. So comparing and contrasting, this is just nice to know information because we're going to talk about these things as we go along, right? Obviously, just having a diagnosis of heart failure means it's chronic, right? It's progressive. If we don't take the steps that we need to take, it's going to get uncontrollable and you're going to end up in acute decompensated heart failure. So it's sudden. We have it, onset is gradual versus rapid. The causes, it's the underlying cause. Acute decompensated, non-adherence to medication, MI, dysrhythmias, infections, uncontrolled hypertension. It kind of goes back and forth for both. Symptoms are less severe in heart failure and more severe, so much so that they use the word severe. Notice, though, you may have with heart failure, it's dyspnea with something. So you did something and now you're short of breath. That's, again, why we probably don't know that we have heart failure for such long periods, is because our body compensates so well. Whereas this is you have severe dyspnea at rest. And this is usually when they come to us, when they're having these acute on chronic issues. Pulmonary congestion, we've talked about, that's going to be in the left side. But for acute decompensated heart failure, it's going to be severe again because it's flash pulmonary edema. You can have systemic congestion, and you can have hemodynamic changes. So generally what we're thinking about here with heart failure is that we want to do things that cause my heart not to be stressed. So we know that there are certain factors that increase myocardial O2 demand. So if you have an increased heart rate, increased force of contraction, or increased afterload, so resistance, your heart needs more oxygen to maintain its normal function. We can do things like clustering care, making sure that the clients are using a bedpan, that they're not getting up and walking long distances, until we get them more stable. That will help decrease the amount of oxygen that they need. But the best thing that we can do is just give them supplemental oxygen, because we have to. It may take us a while to fix that pump. So for our types, again, this is not something that I'm going to test you over, but you can remember that systolic basically means contraction and diastolic basically means relaxation, and that's where we're going to have issues. So you either have a systolic heart failure where your pump doesn't do what it's supposed to, or you have this diastolic failure where you have issues where that ventricle can no longer relax like it should. Systolic failure is the most common cause of heart failure. We know that we have that weakened left ventricle. It cannot contract effectively, which leads to decreased stroke volumes and thereby decreased cardiac output. You're going to have issues with blood backing up to where it came from. And you're going to have issues with those compensatory mechanisms that are going to try to fix you, and instead they're actually making the systolic heart failure worse. Talked about diastolic heart failure. It's more of an issue with relaxation. I lose the ability to have enough space to fill up with the volume of blood. So the left ventricle cannot relax properly, which may impair its filling time. You may have a normal EF, but a low stroke volume, and your body initially is going to compensate for that by having an increased heart rate. And of course, you can have increased atrial pressures, and then again, that's going to cause that whole backup of volume into the lungs or into systemic circulation, depending on which side of the heart you have heart failure. The cause of most of these heart failures, or the outcome of most of these heart failures, are going to be related to your cardiomyopathies. So here, we kind of see a normal left ventricle. I'm sticking to the left again because that's the most common. And I'm able to maintain a normal cardiac output. I have the things that we talked about with excitability, contractility, things that make my pump pump. With dilated cardiomyopathies, you can see that it's going to take a lot more volume to fill this space. Compared, we'll try to do the other one. That's about the size of the other one. And now I have all this extra room here that needs to fill with blood. But I also notice that I have an ineffective muscle. So because I have the ability to hold more blood, but I have an ineffective pump, blood is going to back up to where it came from. Hypertrophic, so this area of the heart is called the septum, right? So it separates the right and left. I have now this thickened area of my heart. It can happen here too, right? But mostly we're thinking here. Because the septum is now larger, I lose space to fill with blood. And because it's thicker, it's not nearly as effective, because now I have this kind of super growth of tissue that is preventing it or requiring more oxygen of it or whatever it may be that makes it that bad pump. So just an increased thickness of the ventricular or septal muscles. Restrictive kind of looks very similar to what normal would look, but it kind of takes a little bit of hypertrophic and mixes it in. So everything looks about the same. I do see that this is a little less than what our normal would be, but the muscles themselves can no longer contract effectively. And usually, again, that's probably an MI that they've had in the past, or they've had these structural changes to the heart, the cardiomyopathies, and they become less compliant. That decreases cardiac output. Again, the stages, I don't care that you know A through D. What I want you to understand is A is starting out, and D is that basically we probably waited for this to happen for too long, and now they are in need of some either mechanical assist device or heart transplant. So if you go through the therapies, you'll notice that a lot of them just start off the same. So your modifiable risk factors: don't smoke, drink in moderation. The only medication that we tend to add here is an ACE inhibitor. ACE inhibitors prevent ventricular remodeling, which means instead of my EF getting worse and worse and worse, that we're trying to keep the function of the myocardium the same. Then you move to your next one. So you're still going to do all measures in A. You still see that we added the ACE. Now we're going to think about adding a beta blocker. And yeah, we're going to probably give it to help lower the heart rate, lower the blood pressure. Those are good things if I have a bad pump. But really, what I'm thinking about for heart failure is that a beta blocker will allow your heart to do the same amount of work with less oxygen. And you can see what that would be an important process for our clients with heart failure. So we'll move on to C. You're going to do everything that you did in A and B, and now we're just throwing the laundry list of things at them. So diuretics, ACE, beta blocker, digoxin, sodium and fluid restrictions can be added in. So think of this more as like, hey, I'm acute on chronic and now I have an exacerbation. Our job is we don't want them to go here, right? So don't go there. But if they do, we need to consider these things. So everything that we've already done, plus assist device. So LVADs typically are the ones that we'll talk about most commonly. If their EF gets below 10, we're going to start thinking about heart transplant. If they're in the ICUs, we're going to think about inotropic therapy to maintain cardiac output, or worst case scenario, we'll talk about hospice care. So in short, we know that we have left-sided, we know that we have right-sided, we know that we have systolic, and we know that we have diastolic. But everything is either a pump or a volume issue. It just so happens that most of our heart failure, the issue is both pump and volume. We do see signs and symptoms of heart failure a lot in children. This is more because they are born with the congenital defects, so they already have a change in the structure and the function of the heart. We also realize that we have said repeatedly that the earliest symptom related to any compensatory mechanism, regardless of age, is going to be tachycardia. In infants, notice not children, we say tachycardia and then we say failure to thrive. And that could be worded any number of ways, failure to latch on, failure to eat, they're not making wet diapers, whatever information NCLEX is giving us about decreased perfusion. Right? Symptoms of respiratory distress and hypoxia because of the bad pump. However, if they develop cyanosis, we need to make the assumption, at least initially, that it's related to the heart. So we're going to make sure that we're going to give supplemental oxygen. However, we can't rule out respiratory issues. It's just more than likely it's the exertion, which is putting a strain on their heart, which is causing the cyanosis. Okay, risk factors, complications kind of go hand in hand. I'm not going to read off the entirety of our risk factors, but basically it's everything that we've always talked about with cardiovascular. Complications are going to be fluid accumulation. So I have pulmonary edema, I have pleural effusions. You can have an ineffective pump and those compensatory mechanisms fail and you end up in shock. You can have issues with kidney function. Hypoxia can lead to dysrhythmias, or the dysrhythmias can lead to the hypoxia. And of course, we've talked about the fact that in circulatory issues, whether it's the hepatic system, we know that we can have that kind of congestion or the accumulation of fluid. So it's cardiac cirrhosis. It's cirrhosis related to the cardiovascular system and not to the actual liver itself. And of course, all these other things that we have do lead us to increased risk of stroke, PE, or DVT. You think about it, this is why we put our clients on antiplatelet medications, anticoagulant medications. This is why we put them on our statin medications. Right? We don't want these bad things to happen. I like this. It breaks it down pretty succinctly. So you have left-sided versus right-sided, and it's left is lung, right side is circulation. So they're saying, by that we're saying the venous system. So left side, your lungs are drowning, dyspnea, rales, orthopnea, weakness, fatigue, nocturnal paroxysmal dyspnea, which, I think that's a stretch, but okay. Increased heart rate, because we've said that's the earliest compensatory mechanism. This nagging cough, you've seen, I'm sure, a million things about pink bloaters and pink puffers and blue bloaters. So you have this frothy pink blood-tinged sputum. And then weight gain, right? Although be careful of weight gain, because if I'm saying what am I giving furosemide for pulmonary edema, the better assessment is lung sounds or SpO2, and not to wait however long to get that next daily weight. Right-sided, we talked about swelling, weight gain, edema, JBD, lethargy, fatigue, irregular heart rates, nocturia, ascites. So just fluid accumulation. So drowning and swelling. Priority interventions, raise the head of the bed. They can't breathe. They can't breathe because they have a bad pump. They can't breathe, so I'm going to give supplemental oxygen. Use enough to maintain SpO2s. IV push medications, consider furosemide. Furosemide's obviously the diuretic. Make sure you're looking at the potassium. Morphine will help, because if you can't breathe, you get kind of anxious. So it does help with that. It will also actually decrease preload and afterload just a little bit. It will help with coronary artery vasodilation, which could help with the ineffective pump in total. If I do have soft pressures, I could consider vasoconstrictors. Be careful though, because if you raise that blood pressure too high, that that can increase the myocardial O2 demand. And then, of course, there's our sodium and our fluid restrictions. And again, that's going to be in those kind of more emergent situations where I know I have excess fluid volume and we know that they're actually having an exacerbation of heart failure. All right, so again, regardless, we're going to treat the underlying cause, because if I don't treat the underlying cause, it's just going to keep happening over and over again. So we're thinking about keeping or maintaining their cardiac output. So we'll need to control their heart rate. We'll need to control the rhythm. We'll need to talk to them about their modifiable, non-modifiable risk factors. We're going to give them the flu and pneumonia vaccinations at discharge. We're going to monitor their laboratory values. We're going to trend their vital signs. And of course, we want to teach them a little bit about medication toxicity if I'm going to send them home with something like Digoxin. Diagnostic testing is pretty straightforward. Of course, I'm going to say that and it's going to confuse somebody, but we're going to look at either the BNP or the pro-BNP. BNP is going to be less than 100. Pro-BNP is going to be less than 900. Again, if we're going to give you a number, I'm fairly certain that we are going to give you a number that is so far out of bounds that it's going to be fairly noticeable. That's my philosophy. We're NCLEX nursing faculty. We're not trying to trick you terribly. We're trying to get you to critically think. So if I give you a BNP that's 10,000, you know that that is a big issue. Of course, we would expect a TEE or TTE because that is that go-to for structure and function and blood flow. We can look for clots. So things to think about. I will say, just from our perspective, since we've already talked about CAD and ACS, that anytime you grab a BNP, you probably should grab a set of troponins as well, just to make sure that this ischemia that is driving the ineffective perfusion is not related to a myocardial infarction. So what I'll show you, and I'll try to draw it the best I can, is that with a BNP or pro-BNP, you're going to start off with your base, and then what's going to happen is that number is going to climb. Now, if once we've started treating it, it's kind of just the same way. We expect that number to start to go back down. It may never come back down to this line, but we're doing things, so I'm kind of like that. When I draw a troponin and it's the chest pain or the other signs and symptoms are related to demand ischemia. So demand ischemia is what we would say because I have a bad pump. So troponins are going to be 0 for me. And I don't care if it's the I or the T. I'm going to say 0, even though I know there's some leeway because I think that we're going to give you numbers that are really elevated. If it's heart failure, instead of it rising and falling over that first 24 hours, 18 to 24 hours, what you're probably going to see is just a little elevation. So this blue dot here is 0, and then their troponins are doing more of this. So they're elevated, but after the first one, the second one is basically the same number or close to the same number, as well as the next one, and so forth and so on. Of course, we can do chest x-rays. It's not going to give me a whole lot of information, but I can see an enlarged heart. I can see the accumulation of either infiltrates or edema. And then we've talked about our EFs. So here's just kind of a breakdown of everything that I've already said. So we know we're looking at the BNP or pro-BNP. It's about stress, not about ischemia. The troponins are more about ischemia, right? So it's definitive for heart failure, depending on which of those two numbers we're using. But I still expect to get a set of troponins, either transesophageal or transthoracic echocardiogram. Remember, the transesophageal is the invasive. The transthoracic can be done at bedside, so it depends on where they're at or how what their symptoms look like. talked about a chest x-ray, and of course they're going to be on continuous telemetry monitoring. Okay, and obviously if you need more information on those diagnostic tests, just refer back to your diagnostic PowerPoint. Cardiac catheterization, if we're having difficulty, if we think that there's some sort of occlusion, maybe that we need to do something about the dysrhythmia, we need to do catheterization, stenting, because it's an MI, it's in the coronary arteries, whatever it may be. And it will help us also evaluate the structure and function a little more because we're putting a catheter directly into the heart. Your erythrocyte sedimentation rate or your C-reactive proteins and your lactic acid are all about telling you that there are inflammatory processes happening somewhere in the body. They are not specific to the myocardium, but, you know, and mostly nowadays it's the lactic acids that everybody likes. It's still good information to have. Electrolyte imbalances may be affected due to medications. Again, you know, your diuretics like furosemide, decrease potassium. Be careful with your ACE inhibitors because they hold on to potassium. All right. We're going to check our BUN and creatinine levels because, of course, this could be related to issues in the renal system because of lack of perfusion. And now your body has been compensating for so long that it can no longer regain control of what it needs to do. We want to reduce their symptoms and reduce the amount of hospitalizations. We want to improve cardiac output, quality of life, prevent progression. That is the big one. Preserve myocardial function. And keep that ejection fraction as close to their baseline as possible. So that's just a lot of patient teaching. And teach them about signs and symptoms of complications. If they stop making urine, if they're having signs and symptoms or a lot of palpitations because they have an arrhythmia, and then if long term with a poor EF, you know that you can go into cardiogenic shock. So in the image to the right, you can see that that is a dilated cardiomyopathy. And you can see how ineffective that pumping motion is to push blood from the left ventricle, and this just happens to also be the right, to push blood from the left ventricle so when it contracts, it needs to go out here. But because I have a bad pump, some of it is still going to go back into your pulmonary vasculature. We know that O2 is good, right? We need to use supplemental O2. We need to provide them with physical and emotional rest. This is where we talk about, again, clustering care, decreasing stimuli. Obviously, a lot of that is just going to depend on the severity. If somebody is in initially with an acute on chronic episode of heart failure and they can't maintain their SpO2s, I'm not going to have them walking to the bathroom. And of course, we want to ensure that these clients actually have their daily weights done. We all know what a big issue that can be. So our plan of care, pretty straightforward, does not differ too much from anything else that we would do. We're going to do frequent vital signs, monitor their I's and O's, up to and including hourly if you're in the ICU. Especially if we're giving like furosemide or on a continuous furosemide infusion. We've talked about the fact that in acute decompensated heart failure, those I's and O's are a better indicator of fluid volume than daily weights. Daily weights are still hugely important. But again, if I'm giving you medications, I need to make sure that that medication is being effective or it's doing what I'm giving it for. Prevent complications, a lot of that will just stem from the fact that blood is not moving around a lot. So you see DVT or VTE prophylaxis, good skin care. We've talked about the fact that nutrition is important to cardiovascular clients. Pain management. Just be careful about masking signs and symptoms of a myocardial infarction. Remember, we're already going to do a lot for this client that's going to help decrease blood pressure, increase heart rate if necessary. But they could still have issues with that demand ischemia, which is going to mimic the signs and symptoms of an MI. In the illustration down here, again, this is that circular process of everything in the cardiovascular system. You know, that reason why students get really turned around on cardiovascular is because everything is the same. So we know that these things are interrelated, intra-related. Client-centered care, just again, preserve myocardial tissue. So initially we may need to get ABGs. Our lab draws are pretty much going to be daily, so looking at the CMPs. You can check their oxygenation status. You can, again, check a chest x-ray to look for fluids or cardiomegalies. We can help determine medication toxicity, especially if we're given Digoxin. I'm going to show you what a picture of toxicity looks like again. Bed rest until the client is stable. Cluster care, dietary restrictions for volume and sodium, fluid and sodium, and of course the old standby, provide emotional support, speak in therapeutic communication, all the good stuff. We have talked about pulmonary edema. We see now in our image to the right here, I do see for sure that heart is enlarged. So I know that this client has an issue with their cardiovascular system. So we know, again, we want to look at MOP. We've already talked about HOPE, right? So positioning, again, high Fowlers, just do what's best or what the client states they feel is best. Oxygen, morphine, diuretics. We know that if I do have pulmonary edema, effective intervention should result in diuresis. That's why those eyes and nose are so important. That's why lung sounds are so important. It's absolutely has to be addressed at least in the initial part of that client's admission. Okay, so frequent NCLEX answers. This is theoretically how taking care of a client with pulmonary edema should go. High Fowlers, O2, cluster care, right? Listen to lung sounds, IV access, medications, Foley if necessary, intubation and ventilation if necessary, and of course document the care that we provided to the client. So you can see that this goes from least invasive up. It starts with raise the head of the bed, but we're also going to include oxygen on there. Health promotion and disease prevention is pretty much the same. Teach the client to maintain healthy lifestyles, talk about diet, talk about exercise, fluid restrictions if necessary. We want them to stop smoking, drink in moderation, make sure that they're taking their medications as prescribed. Because remember that acute episode probably happened because of some other thing going on in that client's life. So, pharmacological interventions. Medication must-knows, right? Diuretic therapy we've discussed. Digoxin, it is a cardiac glycoside. It is an inotrope. We are going to give it to improve cardiac output. However, there's always it depends. We know that we also have to monitor that client for digitoxicity. Digitoxicity can happen at the first dose. ACE inhibitors we'll use. Again, we want to try to prevent remodeling. If we have bad reactions to ACE inhibitors, we can certainly switch them over to an ARB. So your angiotensin receptor blocker medication, your sartans. And of course, we can include that beta blocker to help decrease myocardial O2 consumption, decrease afterload, and make the heart more effective. Inotropes and vasopressors are pretty much the same if needed. Again, this will be in the ICU. Dopamine, dubodamine depends on where your heart rate and your blood pressure are at. But you need to make sure that they are on continuous ECG tracing, that we're getting frequent vital signs, monitoring urine output. We've talked about beta blockers and vasodilators. If we think that they are having chest pain, we can certainly consider nitroglycerin sublingual. If we know that they have a history of angina, then we would expect maybe an isosorbide mononitrate, which is the scheduled nitrate that we would give. Lots of patient teaching around digoxin. And again, this is probably something I've already said. I apologize, but I don't give a lot of digoxin anymore. Every once in a blue moon, it will pop up. But mostly, I see our pediatric clients getting digoxin. But we know we need to teach the client to take their apical heart rate for 1 minute. We're going to hold the medication based on the parameters. These just happen to be the parameters that the books say. So if it's less than 60 for us, so people, adults, children, and then an infant is going to be 90. Children, 60 to 70. Again, that number can change. But what we want to observe for are these issues with nausea, vomiting, dysrhythmias, bradycardia especially, because that's going to show you toxicity. A normal dig level, I do 1 to 2, but it's 0.5 to 2. It's just easier because really I don't care if they're on the smaller side. I only care really when it's greater than 2. But again, dig toxicity can happen after that first dose. We've talked about how to help with preload and afterload. We want to do that because that's going to decrease the effort that the heart has to put forward. It's the same stuff. Positioning, medications, I's and O's. Make sure you're doing your assessments for your loop or thiazide diuretics. Decreasing afterload helps improve cardiac output. And again, you're looking at your nitrates. So your vasodilators, your morphines, your ACEs and ARBs, your calcium channel blockers. Calcium channel blockers, depending on what it is, can also be for the dysrhythmias. So if they have like an AFib, a flutter, we would expect diltiazem. Make sure that if we are using all of these medications, we are evaluating those labs frequently, that we get them once a day or whatever, because again, for some strange reason, people don't understand that potassium goes both ways. I'm giving you 80 milligrams of furosemide and digoxin. That could potentially be bad. So this is a real life client, and this is a client, 5 years ago. So what we see, again, this is not a 30-second strip. Now, I do have my little tick marks down at the bottom, so I can see 5, 10, 15, 20, and then that would be 30. So my heart rate is roughly 55, 58-ish, somewhere in there. We probably are able to maintain cardiac output at that level. we hit them with some digoxin. So this one we gave what's called a loading dose of dig. And this was the client's immediate response to that. I am moving along, my heart rate is good, and then all of a sudden, if we look in this second line here, I see a 6.9 second period of asystole. Your heart's like, oh, I don't want to do that. And it gives me this one random beat, a smaller, much smaller pause, and then another beat, and then another pause. And they go back into their normal rhythm again, and then down the road, another pause. I've said it before, I'm going to say it again. Your infants don't know that they're having yellow halos, right? It's nausea, vomiting, it's dysrhythmias. This is periods of asystole. This was to a client that received a loading dose of digoxin, and this is why the outcome needs to be evaluated thoroughly. Being dramatic there, they died for 6.9 seconds. Their heart stopped for 6.9 seconds. So yeah, they can say technically they died. All right. So kind of a list of things that I would expect you to be familiar with. The mechanism of action, I don't care about. We've talked about these things, but I expect you to be familiar with furosemide in caring for a client with heart failure. Hydrochlorothiazide is probably where we started off if they were being treated for hypertension. So, that's typically the first diuretic we start them with. I don't use as much HCTZ as I do furosemide. And again, that's because most of my clients already have kidney issues. Potassium sparing is spironolactone. We use ACE inhibitors and ARBs to prevent remodeling. We use vasodilators such as hydralazine, isosorbide mononitrate or dinitrate, nitroglycerin, nitroprusside, because that's going to decrease afterload, which is going to make it easier for the heart to pump. We said we give beta blockers to prevent morbidity and mortality, right? Promote or reverse remodeling. It allows the heart to do the same amount of work with less. Our inotropes, we talked about dopamine and bubotamine, but we're only going to do that if they have a really bad EF or if they're symptomatic and need to be in the ICU. We talked about digoxin and what a normal dig level is versus what toxicity is. I think digibind will come up later. Digibind is the antidote for dig toxicity. Watch for your increased risk of dysrhythmias. Morphine, it helps with your respiratory issue. It helps with anxiety. And we said that it does cause a decrease in preload and afterload a little bit. You know why we do dysrhythmics and anticoagulants. We've talked about hypokalemia causes ventricular dysrhythmias and increased risk for dig toxicity. I'm going to say that so does hyperkalemia and most of your electrolyte abnormalities. So we're going to do our patient teaching. So you can see in this drug alert, they do specifically say hypo and hyperkalemia. And then we look for anorexia, nausea, vomiting, fatigue, headache, depression, visual changes. So what I want us to think is like NCLEX knows that you guys know that it's yellow halos. Oh my goodness, it's yellow halos. They're not going to ask you that. They're going to say, hey, your client was admitted with a new diagnosis of heart failure and was giving a loading dose of digoxin and is now experiencing nausea and vomiting and complaining of a headache. What action should the nurse take? You're going to get a dig level because you just gave them digoxin and now they are displaying signs and symptoms of dig toxicity. So there's your antidote, the Digoxin Immunofab, the Digibind. Can be used for extreme toxicity. Again, that's not your call. That's going to be the healthcare provider's call. But we need to find it first. So we talked about changes in our rhythm when we have changes in our electrolytes. This is not something that I expect entry-level students to know, but all of a sudden I'm having changes, and those changes are associated with hypokalemia. So if you remember, hyperkalemia was those large peaked T waves. Well, this is just called a large U wave. It don't really teach you folks, at least I don't teach my students about U waves, but what I do see is that here is the T wave, and then all of a sudden I have this other wave, and it's generally because of hypokalemia. So you have the inverted T. Here we have some ST segment depression. Here we have a T and a U wave fusion. So they've just all combined together. This client has a lot going on. You can see here the heart block with the PR prolongation, and I think you see it better down here. So you have a heart block. It looks like he's having some sinus arrhythmias, so that's done with breathing, and then we kind of pick up where we see normal R to Rs that are pretty much consistent throughout. So we just need to know, hey, I'm seeing information here that's pointing me in the direction of I should check the MAR and I should check the electrolytes. And I love my students because I know they all come in and we're there early. We go through their lab results, but if those lab results aren't back and you don't bother to continually check, you could have serious issues. So therapeutic procedures. So what I want to think now is that we have taken care of this client. They've had a long-standing history of heart failure, and now their EF is just so bad I have to do something. That's something that I have to do is probably going to require the use of a pump to assist them. So pump failure, I want to provide them with a pump. So you're going to talk about a ventricular assist device. It's just a mechanical pump for clients usually with really, really, really bad EFs. They may be eligible for heart transplant. Again, that kind of depends on the client. But we can send them home with this machine. This is now basically the size, I don't know, maybe a half of a cereal box, if not smaller. So we will do a lot of patient teaching, but this does allow them to have some semblance of a quality of life. Here's all of my patient teaching guide. Again, I think that we've talked about health promotions when we talked about the flu and pneumonia vaccine. We talked about smoking cessation, weight loss, diet, exercise, teaching them signs and symptoms of exacerbations, teaching them about their medications, their dietary issues. So we want to have them, again, report any kind of weight gain of 3 pounds in 2 days or 3 to 5 in a week. And tell them most people will know that they're putting on water weight. So if we kind of explain it in general terms, you want to make sure that they're taking that daily weight at the same time each morning, that they're wearing approximately the same things. We said if you can't eat, or if you can't breathe, you can't eat. So we're going to teach them to eat maybe smaller, more frequent meals because they need that energy conservation, but they also need the food or the energy. So we can't not eat just because we don't feel well. So we've got to do some patient teaching there. And of course, your ongoing monitoring doesn't really change from cardiac client to cardiac client. That is the end. So heart failure in a nutshell, right? It's a pump issue, can lead to a volume issue. It's generally related to cardiomyopathies. We want to maintain our cardiac function as best as possible. We're going to do that through teaching. So, healthy lifestyles, modifiable versus non-modifiable, and through medications. They need to understand the medications and why they're taking them. And then once we get further down that kind of road, if we need to talk about LVADs or heart transplant, we can.